So we're going to be going through several times of mental illness today. So we'll start just with a brief introduction, then we'll be going through depressive disorders, anxiety disorders, psychotic disorders, personality disorders, and a few other disorders as well that covers ADHD, and also leave room for other things that you would like. And then we'll have a bit of time for the discussion period. So I guess we can start off as well. So just to know in general, so for the introduction, mental illnesses are characterized by alterations in thinking, mood or behavior, and mainly what we look for is that they're associated with significant distress and impaired functioning. So just having some alteration in thinking or just feeling a little bit off some days is really not enough to be diagnosed with a mental illness. It really either needs to be very distressing for the person and also be impaired functioning as well. So you have to have some difficulty at work or at home or in your interpersonal relationships, or sometimes in all three of these spheres as well. So this is really what we look for. Mental illness in Canada, so this is what I just talked about, so it causes significant distress and impaired functioning. And it can really affect individuals of any age. So we have child psychiatry up to geriatric age, so above 65, and even infant psychiatry in some cases as well. So it really spans the whole lifespan. Within Canada, so there are 5 million Canadians, so about 1 in 7 Canadians will use health services related to mental illness annually. So this is a lot. This is if you just think amongst you, your friends, your family members, 1 in 7 a year will use some services. Women overall are more likely than men to use these health services for mental illness, especially between 25 to 39. And this is important not because women actually have more mental illness, but just because women in general tend to be a little bit more health conscious. This is a stereotype, I know, but in general women will more likely present. And sometimes they'll also go and poke their male partners to also come and present, and that's sometimes why we see men also in clinic. And mental illness have the potential to impact, like I said, every aspect of an individual's life. So it can affect your relationships, your education, work, your community involvement, social spheres. So this is usually when we try to help out in psychiatry. So just a little bit of the history of mental illness. So historically, people with mental illness mental illness in general has a social stigma attached to it. There's some cultures where it was believed that a mentally ill member implied that there was a hereditary disabling condition in the bloodline, threatening the family's identity as an honorable unit. This is still present actually in many different cultures too around the world, and it's something that we strive to work through and to have less social stigma as well. And it's also something when I'm seeing a patient that I take into context what the stigma may be and also what cultural background they come from and how this may influence their interpretation of the illness and also their treatment. And overall, yes, the views of mental illness have changed over time, but there's still a lot of work to do. So that's a little bit of the intro. I'm going to start now with depressive disorders. So talking a bit about depression and what it means and the treatment for it. So just know overall, so clinical depression is different than everyday sadness. Some people will think, I've been depressed for a day. I had a rough day at work. I felt a little depressed. We use it almost as an idiom in Canada to say that we've had a rough day, or my job made me a little depressed. My boyfriend's depressing me today. That's not what we talk about with clinical depression. For clinical depression, it really causes a profound, long-lasting symptoms that disrupt a person's ability to perform routine tasks. So this is way beyond sort of the day-to-day feelings of sadness. Yes, we talked about it as well. So the signs and symptoms of depression, there's a little cartoon here. So there's several different facets that we look at. So it's not just feeling sad, but often this person will have disturbed sleep. Some people sleep way more. Some people sleep less. They'll also eat more or less too. The appetite can also be changed. People can just have a loss of interest in their regular activity. So usually someone who loves to listen to music, let's say, just doesn't feel any pleasure doing it. They may also have feelings of guilt or worthlessness, thinking back to things they did in their lives. I shouldn't have said that years ago. I'm a failure somehow in my life. And just these thoughts, these negative thoughts can really predominate. Within that as well, they may also have become very isolated as well. They may start thinking about death or suicide too, which is something that we really try to screen for and try to offer as much help as possible. And they may also have low energy. So it's really just a cluster of many different symptoms. It's not simply feeling sad, but it actually affects the way that their body feels and their ability to function. You could sort of imagine, too, if someone is that tired and really has lost interest and is cutting themselves off, this is just more than the usual, and this is what we call clinical depression. There are multiple risk factors for depression too, so this is really something also that's important in considering the diagnosis and also the treatment. So one is the genetic factors. So if you look there at the top left corner, so the genes, there is a genetic predisposition to depression. So someone who has a family history, let's say their parents, their siblings were depressed at some point, this also puts them at a higher risk. Within that too, so the actual biology, so the chemical makeup, which may or may not be genetic factors actually, so it's sometimes different things to do with the way that their genetic makeup is made. So this may influence the way that their brain functions and may predispose them to it. Within this too, the lifestyle, so now bottom right we're talking about, so different factors, so having, let's say, a poor diet, using different drugs or alcohol, not exercising a lot, not sleeping regularly, all these factors can also contribute. And the last is the environment. So this is a very, very important thing for depression. So let's say having a lot of trauma throughout your life as well can be a significant risk factor, and so can just having major losses. If you had a close family member, a spouse who died recently, losing your job, or just many stressors that we all experience in our lives. So, if you have a combination of all these things, this is when it can lead to depression. For some of the biological changes, so this is actually very interesting research that was done. So the brains of people with clinical depression is actually different in many ways from people who are not clinically depressed. So that's why it's there are clear indicators that it is a brain disorder and not just something that people, they just don't want to get up out of bed. You can actually see changes in their brain hinting at depression. So one is the neurotransmitter function. They actually have decreased function of neurotransmitters in specific parts of their brain, and a decreased number and size of some brain cells too, and also the size of certain brain structures. So actual parts of the brain are actually smaller. So some of the main ones that are affected are the amygdala and the hippocampus, and this is really what leads to impaired memory also with time. So people can feel sluggish, they're not performing memories in the same way, and can lead to memory problems later on. And it also affects the prefrontal cortex. So that's really just the front of the brain, and this can impair decision making. This is not to mean that people with depression have, it's not like Alzheimer's or dementia where they're forgetting things, and it doesn't mean that they're incapable of making decisions. It just means that overall everything is a bit more sluggish. There's this question too of cause or effect, meaning do people with depression, is it because their brain is different that they develop depression, or is it because they have depression for so long that the brain looks like that? And that's something that we're still looking at in terms of research. So now, how do we treat depression? So I like this quote overall. So mental illness is not accurately described as a disease of the mind and the brain. Treatment must attend to the whole patient. So like I was saying that there are many different factors that can increase your risk of depression, this is something that I always bring into treatment with someone. So I like this this little graphic overall to say, so there's different spheres that I always look at when treating someone for depression. So one, let's start actually with, I like the blue one. Let's start with the blue one in the back. So if someone comes to me with somewhat of a mild depression, let's say they're still doing okay at work, but they're just feeling a little bit more sluggish, not sleeping well overall, and they've had some life stressors. So one of the main things I'll recommend is lifestyle modification. So talking about healthy nutrition, exercise, getting out a little bit more, getting some sunlight, that is actually can be very helpful for some people, just getting them on the regular schedule. This is just for mild depression though. And within that too, so also the purple beyond it, so the social also. So making sure that this person doesn't become completely isolated, that they're still, even though they're not feeling well, still really to get out, to see their friends, to see their family. This has a huge, huge impact for many people, that we want to make sure that they don't completely withdraw from physical activity and also from their friends and family. Let's say I see them at a point where they're a little bit more moderate to severe depression. In cases like that, I'll recommend psychotherapy. So there's cognitive behavioral therapy here, there's mindfulness, there's other types of counseling too, which hopefully they can access in some way. And this can be very, very helpful. I'll talk a little bit more about therapy afterwards. And I'll often recommend therapy and, if necessary, too, antidepressants. So the ones that often I'll be prescribing then are the pharmaceutical antidepressants. There are many different classes too that I'll go through. And there are also some natural products too that can function as antidepressants, so they're not as potent as the ones that we have from the pharmacy. So within antidepressants, there are many different types. I'm not going to go through all the names now, but there are different types like serotonin reuptake inhibitors. There's serotonin norepinephrine reuptake inhibitors, the atypical antidepressants, and many different classes and different names. So I'm sure if any of you know someone who's been treated with depression, you've heard some of these before. And just to know, so how long does it usually take to have some effect? Within 1 to 2 weeks, I'm looking for some side effects to see if it's tolerated by the person. I usually don't expect much of a positive effect for at least 4 to 6 weeks. it may actually be up to 6 to 12 weeks to see the full effect of an antidepressant. So at around 4 weeks, I'm expecting a little bit of a change, at least, in that they don't have major side effects, and then I'm just waiting a little bit longer to see if they're getting much of the effect of it. So what's important actually is that I encourage people, if they tolerate it and if it's a good medication for them and their depression improves, to actually continue it for longer, and then once the depression is resolved, to actually continue, if it's their first depression, for a minimum of 6 months afterwards. And if it's not their first depression, so it might even be even longer, because there is a chance that once you stop the antidepressants that the person will actually relapse. So they may stop the antidepressant and get depressed again. There is an effect also, so antidepressants on the brain, so it increases the amount of serotonin on the brain. I'm talking about the SSRI class of medication now. And so you could sort of see here that these are the areas, little parts of the brain that are lit up, the little red and yellowish areas. So those are the parts of the brain in this person who is taking a specific antidepressant. And now we'll talk a bit about psychotherapy. So I've mentioned some types. So there's cognitive behavioral therapy, there's IPT, which is interpersonal therapy too, which is useful for depression. And psychotherapy is incredibly useful because it helps you develop new coping skills and more adaptive ways of thinking about your life problems. So the way I think about it is almost imagine like you pull out your back, you carry a really, really heavy box and you injure your back badly. Psychotherapy is sort of like doing physio for your back. It teaches you how to move properly. It will help prevent re-injury in the future. Whereas for some people, if you pull your back so badly, you can't even do physiotherapy. You can't get out of bed in the morning. You can't do anything at all. And in that case, an antidepressant or specific for back pain, a pain medication may help to just help you actually benefit from the physiotherapy. So in people where it's severe enough, the combination of both is most useful. So bipolar disorders, we have bipolar type 1 and bipolar type 2 disorder. Bipolar type 1 is what was previously referred to as, still sometimes people call it manic depressive disorder. And it's characterized by periods of severe mood episodes. So you can have mania and you can have episodes of depression. And I'll go through that a little bit in more detail. Bipolar 2 is a milder form of the mania. So instead of having a full-blown mania, we have little manias, which are called hypomania, but you could still have full-blown depression with it. So these are the bipolar 1 and bipolar 2 disorders. So for mania, when someone is manic, people call it like a high, or you're feeling very up. But it's not just feeling good. It's really above and beyond that. It's feeling elated, the fact that you don't need to sleep, you're thinking very quickly, you're speaking very quickly, your mind is just rushing a mile a minute. And it may sound a little fun at first, but it usually can get to the point, well, in some people it can get to the point where it becomes a bit too much, to the point where they may do dangerous things. They don't realize that they may go out and spend a lot of money or drive very fast and be at risk for car accidents. They may do other impulsive things or things that they wouldn't usually do, like spend much more money or, use drugs that they wouldn't actually do, or have thoughts or feel like they have superpowers that they wouldn't under a normal state. So what may start off as just feeling pretty good can go off into a very dangerous direction. And then the opposite of that is having a depressive episode. So this is much like the depression that I described before, but it can be an even sort of harsher crash when you're coming off of mania, where you sort of feel on top of the world and everything is great, and then you crash into a depression afterwards. And important to keep in mind, actually, for people with bipolar and for bipolar disorder, they often spend much, much more time in a depression than they do mania. So if you're looking at this on, many movies will characterize bipolar disorder, and it just looks almost fun, that the person seems to be high all the time and things are great. It's not actually what the experience is for many people with bipolar disorder. They'll spend a lot of time depressed and a lot of time trying to get sort of their life going because everything is so slow and they're not feeling well, and then they'll have these brief manic episodes that may last for a week or so and don't happen that regularly, so maybe a couple of times a year. Obviously varies person to person. Some will have more often, some will have less, but it's not always the mania that people have. And so you may have the full-blown mania, or with a hypomania, people will often feel a little bit more energetic, but not get to the point where they'll have altered thinking, maybe weird thoughts or just strange thoughts about having superpowers, or they may not go to the full extent of doing dangerous activity either. So they just feel a little bit better, but they'll still have these crashes of depression afterwards. So overall, for bipolar disorder, so this affects about 6.6% of the population, so less than 1%. And on average, the first time people will have a mood episode is around 18 years old. Overall, the male to female ratio is about 1-to-1, maybe with a little bit more men, but overall it affects men and women about equally. And really, family history of bipolar disorder is the most important risk factor. So this is always something that we ask in clinic. If someone is presenting with a new manic episode, is there anyone else in the family? And so the treatment overall, so we have to sort of think, like I mentioned too, so in mania you have in bipolar disorder you have the highs and you have the lows. So the treatment also depends on how am I seeing this person at this point. If I'm seeing them in a high, you want to bring them down from that high. You just want to make sure that they don't do anything dangerous, that they're getting a little bit more calm, but hopefully don't crash down to a depression. So we'll use a class of medications either called benzodiazepines to bring them down and calm them down, or we'll use antipsychotic medications, which are a bit of a misnomer, and with time we'll actually change the names of medications from antidepressants, antipsychotics, to the actual function of how they work, because it's not because the person is psychotic necessarily that we're using an antipsychotic, but this just helps calm them down a bit. If they're very low in a depression, we don't actually want to use an antidepressant like in depression, because some antidepressants can actually make them manic. This is something that's been well shown in the literature, and there is some biological basis to it. So we don't give them a regular antidepressant. We can give them an antipsychotic which has an antidepressant effect called lurasidone, or lamotrigine, which is an anticonvulsant, can also work as an antidepressant for people with bipolar disorder. Then once I've brought them down from either the high or tried to treat the depression, we're also thinking long-term. How do we prevent more and more episodes of mania? For this, we can often give them either lithium or Epival or another mood stabilizer to try to sort of not have as big ups and downs throughout their life.
I believe we have one line open.
Hello.
Hello? Would you like to ask a question?
Yeah. In terms of how long does each episode last? Like, for example, let's say the manic episode, how long, in terms of, does it last, 5 days, 2 weeks, 1 month? How long?
Great, that's a great question. Thank you for asking it. So I didn't say exactly. So for the manic episode, I'll ask them a minimum of 4 to 5 days or so where they're feeling very high. For hypomania, it could be a little bit longer. And actually, even for mania, sometimes it can last. But the minimum should be 4 days for a real manic episode. So it's not just, for some people they'll feel, I was feeling really good for a day, so I didn't sleep. I had a big project at work. I didn't need sleep. I felt great. I was up and at 'em. That's not what we're looking for, and that's not what we describe as mania. It really has to be sort of this internal drive that you don't need to sleep. You're sort of functioning with the motor way quicker than usual. It also, too, so when I ask the people the question of, have you ever had a time in your life where for 4 or 5 days you didn't sleep, you had a lot of energy, it's also important to think of the context. So some people will say, I met my first boyfriend. It was when I met my boyfriend, I was madly in love. I didn't need sleep. I felt great. That's also not usually the context that, that for me is not a manic episode. It really has to be much stronger than that for a minimum of 4 days. Sometimes it can go on for weeks, though, without intervention.
Mm-hmm. Okay. And how does it start? Like, for example, you said the causes for depression would be a major stress, in the environment or genetics. But in terms of, especially with mood disorders, I was just thinking, does it start for example, in a day you feel high and low, and then at the time the interval gets longer and longer, and then at some point you become as if for 4 days you feel all down, and then for 4 days you feel all high. So how does it start really? Is it quickly get 4 or 5 or 1 week of mania in the other manic episode, or is it it starts slowly and it builds up to a big interval of time?
Mm-hmm. Okay, good. Thank you for the question as well. It's a great question. So there are actually further subtypes of bipolar disorder which I haven't outlined in this, which I haven't been talking about just because I wanted to make it a little bit, just to talk about the major categories. But so for some bipolar disorders, let's say the most common will be about, let's say, a few weeks of feeling mania maximum, and then you would be depression often for a few months afterwards. So it will not be 1 week. However, there are some people called rapid cyclers, or some people will just have, so rapid cyclers may actually have many, many mood episodes per year, meaning you may be high for a few weeks and then back down and then high again the next month. So it can be actually much more frequent. That said, that it's quite rare to see that, and it's something that is usually will be mania for a few weeks and only a few manic episodes per year, and most of the time depression. So it should not be changing on a week-to-week basis.
Okay. And also another question was regarding, you said for males and females is usually like the ratio is 1-to-1. But for example, in women, like for example, they have a lot of like hormonal changes, like estrogen, like other stuff, and that also affect, like for example, dopamine, reuptake or other stuff. I was just wondering, like, so for women, why do we see like? I know that it sounds like so. It's just like, isn't it like for women it would be like more or less, or is it that estrogen is maybe like a protective factor for a female? Like, how does it work?
So that's also a really great question. So for women, the estrogen earlier in life is not seen. So I think also what you're kind of talking about is how women may have more hormonal changes to do with their periods and the menstrual cycle. So there's actually a separate, that doesn't lead to a high risk of bipolar disorder. There are some specific disorders to do with women called, let's say, there's one called premenstrual dysphoric disorder, where women may actually feel a bit more depressed in the time leading up to their period, but not to the point where they're actually bipolar. So they may have a little bit of a lower mood in a very cyclical fashion, and you can go and actually talk to your doctor to see if it's usually around the period, like a few weeks before your menstrual cycle, that you seem to have these mood changes. There is a second peak of bipolar disorder later in life, meaning so that it will usually be diagnosed in around 18 years of age, but around 40s and 50s and a bit later, there are more people who will then be diagnosed. So it hasn't been clearly shown if it's actually related to estrogen changes later in life or not. So it's not actually, the bipolar disorder is actually thought to be more related to disturbances in sleep and other factors in the body, and not specifically estrogen. Great. Okay. So next I will be speaking about anxiety disorders. So overall, anxiety is a normal. So anxiety really at the baseline is a normal reaction to stress, and it can be beneficial in some situations. So it's almost like this idea that if a bear is coming to chase you, you want to be a bit nervous. You want to have your fight or flight response coming in. But an anxiety disorder is when you're at the point where there's too much fear or anxiety, which is sort of out of proportion of the stressor. So if you have a bear chasing you right now, it's normal to feel anxious, but for some people, even if there is no immediate stressor, they'll still feel very nervous and as if there's an immediate threat coming for them. Overall, anxiety disorders are the most common mental disorders, and they affect nearly 30% of adults at some point in their life. So this is 30%. This is huge. This is 1 in 3 at some point will have this. Overall, women are more likely than men to have anxiety disorders. So I'll go through about 5 anxiety disorders. There are more overall, but I'll talk about some of the common ones. So the first will be generalized anxiety disorder. Then I'll talk about social anxiety, panic disorder, agoraphobia, and general phobias. So the first one, generalized anxiety disorder. So this is what people think when we're talking about anxiety is that, I just worry about everything. Generalized anxiety disorder is really a level beyond that. It's not just someone who worries all the time. It's someone who has been worrying for minimum 6 months, let's say, but it's often their whole lives. They've been a bit of a worrier, but they also have physical symptoms of this worry. So they're always thinking about the worst case scenario for many different things. For their kids, what's going to happen to them, their finances, their life, their health, everything overall. They may feel also very irritable, keyed up, restless all the time. It may also drain their energy because they're worrying all the time. They may not sleep well either. So it actually presents a whole syndrome overall, and it impairs their functioning in some way. If you're someone who worries all the time, but, overall you're not too distressed by it, you've always been someone who worried and it's okay for you, then, you're not going to come see a psychiatrist. Usually when people have generalized anxiety disorder, it's that it's taken over every sphere of their life. For the next one, social anxiety disorder, I'll go over a bit of the treatments at the end of all 5, so just to mention now. So for social anxiety disorder, this is quite common overall, so it can be about 7% of the population that has social anxiety disorders. These are people who feel uncomfortable in social situations. They worry about being embarrassed or humiliated or rejected, and so sometimes they'll just avoid, talking to people in public because of it. Or they will either avoid it or they'll go to the party, let's say, but just will be really uncomfortable the whole time, try to get out of there as soon as possible and just really endure it with a lot of anxiety. This can come up with extreme fear of public speaking, meeting new people, or some people also just don't want to eat or drink in front of people in public too. So this is quite common, and for some people, it may just be for a specific part of their life too, that maybe I just don't want to eat and drink for a period when they're younger, and then they may grow out of it or not. The next one is panic disorder. So this is an anxiety disorder where people will feel panic. So this is different from the generalized anxiety disorder. So with panic disorder, you'll feel panic attacks. And panic attacks are this overwhelming sensation where you can't breathe, your heart is beating really quickly, you may have shaking in your arms, you may be sweating, and they don't last very long, but you really feel in this moment like you're going to die. Like it's the end of the world, like your heart is going to beat out of your chest, and your mind just jumps to the worst case scenario. And really, for this period of time, it's just unbearable for the person who's going through it. And when they don't have it, so once they've come down from the panic disorder, all they can think about is, oh my God, is that going to happen again? When is my next panic attack going to come? Is it going to be when I'm out in public? Is it going to be when I'm at home? And they may just choose to limit their life so that they don't have another panic attack in some ways. So for panic disorder, it's also really for all the mental disorders we're talking about today, but also for panic, to make sure that they don't actually have a medical illness that could be causing it. So it feels maybe like you have a heart attack. We have to make sure that it's not a heart attack. If they have to make sure they can go to the hospital, that there is nothing else. And then once we've made sure that there's no medical cause for it, then we can treat the panic disorder appropriately and make sure and see if there is a cause that's triggering these panic attacks and how we can help them treat it. The next is agoraphobia. So agoraphobia is a fear of being in a situation where escape may be difficult or embarrassing, or help might not be available. So it's usually like places like fear of open spaces in some way, like being, let's say, in a public transportation, like on a bus, being in a big mall where there's plenty of people and you can't get out, being stuck in an elevator with someone, or being stuck in a crowd. And it's usually this fear is out of proportion. They don't even want to leave the house, or they will refuse to take the bus. And it should be for at least 6 months or more. And it has to be in more than one situation as well. It's not just a fear of elevators. It should be a fear of a few different spaces. Or sometimes either here they'll refuse at all, or maybe they'll require someone to bring them every single time they leave the house. So this can also be very debilitating for people that they may not leave the house, they may not see friends anymore, they may miss appointments, they may just have their whole life on hold because of the agoraphobia. And the last one I'll talk about for the anxiety section is specific phobia. So this is very, very common. This is up to 10% of us that can have a specific phobia. So this is a phobia, I think it's a bit more, people know about this a little bit more, something that's more openly talked about. So it's fearing something specific. So it's a persistent fear of a specific object, a situation, or an activity that's generally not harmful, but also can be. So the people know that their fear is excessive, but it's really hard to overcome it. So some examples are fear of flying. Some people, they just don't want to get on a plane no matter what, even though they know probably nothing's going to happen, but they're on the plane, they're shaking, they're having, they're panicking. It's just an awful, awful situation for them. For some people, it's a fear of spiders. They know the spider is not going to harm them if we don't really have any of those really scary ones in Canada, but it's still terrifying to see the spider. Or a fear of snakes, that may not be dangerous. And so I think many of us have either experienced this ourselves or know someone close to us who has one of these specific phobias. And so the treatment overall for different anxiety disorders really depends, first of all, on which one of the 5 anxiety disorders we have overall, and also on the person. So we have to think for generalized anxiety, the treatment would be very different from a specific phobia. And the treatment would only be if the person really wants to have some treatment for it, if it's impairing their life in some way that is really debilitating. One of the main things that I recommend for many of these people is psychotherapy. So cognitive behavioral therapy can be very, very helpful for some of these, for social anxiety, for generalized anxiety disorder. For panic, it can also be helpful. And for phobias, it's more about exposure therapy. Actually can be very helpful, but so can other types of therapy too. So exposure therapy, let's say you're afraid of spiders, they'll help you get a little bit closer to a spider, maybe not a real spider, they'll show you a picture at first, and slowly, slowly develop a sense where you're a little bit more comfortable. Or if it's a fear of flying, they'll do the same thing. There's also some medications that can be very helpful too. So this is often when I see people with generalized anxiety disorder, if they don't have access to psychotherapy or they've tried it or they're not interested, medications can also be very helpful. And for this, we can either use medications like the antidepressants I outlined before. There's specific ones that are excellent for anxiety. Or benzodiazepines, shorter term, can be helpful too, or combinations of other medications too. Within this too, for anxiety, things like stress management can also be very helpful. So exercise, doing things like weightlifting, and also has been shown to be helpful for generalized anxiety disorder. Avoiding caffeine also, if you're sort of already someone who's a bit more anxious, keyed up, don't drink too much coffee. You've got to cut out the energy drinks, the coffee as much as you can. There are also some natural products which can be helpful too. So one could be lavender oil is something that's sometimes helpful for people, but it always has to do with how severe is it and what works best for the person. So we always try to take an approach that is as comprehensive as possible and is something that the person really feels good about too.
Okay, you can go to the next section.
Good evening, everyone. My name is Arwa. I'll be taking the relay from Melanie to speak about you now about psychotic disorders. So a psychosis is defined as a loss of touch with reality, and it can manifest itself through delusions like fixed or false beliefs, as well as hallucinations, which are an alteration in a sensory modality, most commonly auditory or visual. So there are many types of disorders that can imply psychosis, for example, schizophrenia, but also schizophreniform disorder, as well as schizoaffective disorder, delusional disorder, and brief psychotic disorders. So the types of psychosis are very various. So, for example, schizophreniform resembles schizophrenia, but the duration of illness is less than 6 months, whereas schizophrenia is 6 months. The disorganization has to be more than 6 months. And unfortunately, most patients will progress to schizophrenia from schizophreniform disorder. Also, there is schizoaffective disorder, which implies episodes of psychosis and mood episodes, including mania and depression, as discussed previously. Also, there's delusional disorder, which are fixed, false beliefs that cannot be challenged and are not accompanied by hallucination. The treatment also includes antipsychotics, but it's much more difficult to treat in that situation. I wanted to speak about brief psychotic disorder. So it's an episode of psychosis which lasts less than a month, so it's very brief. This type of psychosis can be drug-induced, and many drugs can cause psychosis. For example, cannabis and amphetamines, like speed, being the two most common, but many other substances can cause it too. Now, schizophrenia is more of the chronic and severe mental disorder that affects how a person thinks, feels, and behaves. So people with schizophrenia may seem like they have lost touch with reality. Symptoms of schizophrenia usually start between ages 16 and 30. In rare cases, children can have it too, but it's, as mentioned, it's more during the young adulthood. Also, this disorder is thought to affect approximately 1% of the population. And just like a bipolar disorder, it affects a little bit more men than women. So for the diagnostic criteria, in order to get a schizophrenia diagnosis, you need to have at least 2 of the following symptoms for at least 6 months. So there got to be delusions, hallucination, or disorganized speech, as well as disorganized or catatonic behavior, which is catatonic can be described as loss of let's say, like a fixed kind of a figure, a diminished movement, as well as negative symptoms, which is more like ambivalence, diminished motivations. So at least one of the symptoms must be the delusion or the hallucination or the disorganized speech. Continuous signs of the disturbance must persist for at least 6 months, during which the patient must experience at least 1 month of active symptoms, or less if you treat it successfully. And also there's got to be social and occupational deterioration problems occurring over a significant amount of time. These problems must not be attributable to another condition. So I just wanted to mention the genetics in schizophrenia. Actually, so we mentioned that the population with no family history was 1% of empirical risk. When one parent is touched by this disorder, it can be between 7 to 16%, and when both parents are touched, it's more than 50% chance. When you have monozygotic twins, it's also between 40 to 50%. When I mean by monozygotic twins, I mean identical twins. So the genetics play a great role in this disorder. Also, there are other risk factors that can predict the schizophrenia disorder. For example, the regular cannabis usage, especially in the developing brain, and that is until 25 years old. Also, the obstetrical complications and prematurity of one individual, as well as immigration, which is more and more studied nowadays. Also, the fact that a person is born in an urban area, so in a city. So for the treatment, before I start off with the treatment, I just wanted to mention that the early intervention has been shown to improve the outcomes. The initial presentation of psychosis often demands hospitalization to address the patient's new symptoms and to start an antipsychotic medication. Maintaining treatment can be challenging since many patients do not perceive that they have an illness or because of important side effects. Stopping medication, unfortunately, increases the risk of psychotic relapse. So the medication to treat it is antipsychotic medication, and it blocks the transmission of dopamine in different parts of the brain. This contributes to both the therapeutic effect and the side effect profiles of the antipsychotic medication. So when you will get the slides, you will get to see the different pathways in which dopamine can interact into the brain. Schizophrenia actually is not just the fact that there's enhanced dopamine in the whole brain. It's actually some parts of the brain where other parts of the brain are have actually diminished the dopamine transmission. So when you will get the slide, you will be able to see the different pathways that can explain the different symptoms that you can see in a schizophrenic patient. So now I will speak about the personality disorders. So for sure, a personality disorder is characterized by a pattern of distortions in cognition. So it's the thinking patterns as well as the affect, so the mood, the feelings, and interpersonal relationship. And in order to really have the diagnosis of personality disorder, it has to cause severe dysfunction in the everyday living of a person. So you can have traits of personality disorders without having the disorder itself. It really has to cause severe dysfunction in an individual. Also, it has to start in the teenage years or the early adulthood in order to make a diagnosis. So now we will speak about the different types of personality disorder. So traditionally we divide them in 3 clusters. So it's cluster A, B, and C. Cluster A, which are more known for like the odd, bizarre, eccentric cluster, include the paranoid personality disorder, schizoid personality disorder, as well as schizotypal personality disorder. The cluster B is known more for the dramatic, erratic behaviors, and it includes antisocial personality disorder as well as borderline, histrionic, and narcissistic. Finally, the cluster C is more known for the anxious, fearful cluster, include the avoidant personality disorder, as well as dependent and obsessive compulsive personality disorder. So we'll go one cluster after the other and speak more about each of the disorders. We'll start by the cluster A. So for sure, I will try to provide some example for every personality disorder. But eventually, after this lecture, you will be able to to diagnose different personality disorders in, for example, the films that you will see, or the any sitcoms or whatever, series that you are watching. Usually, it can be quite flagrant. So for the paranoid personality disorder, is really known for the tendency to mistrust others and to suspect that their motives are hurtful. So that's for paranoid. After, we have the schizoid personality disorder, which is a tendency to not be able to relate to other people or to have a restricted range of emotional expression. For example, I don't know if you've seen Mad Max. Well, Mad Max can be a good example of a schizoid personality disorder. Usually they don't really, they prefer to be alone. They don't necessarily seek other people. They tend to bond very well with animals more than with people. So and usually they will have like jobs that imply not so much contact with people. For example, night work, night shifts, janitors or things like that. So schizotypical. So moving on with the other cluster A personality disorder. So the schizotypal personality disorder is a tendency to feel very uncomfortable in close relationships and to have odd or distorted thoughts or perceptions. For example, a good example of that would be the whole Addams family. So it's a little bit of this odd, distorted thoughts, perception. They also have a tendency to speak in a certain melody or prosody in their voice that is a bit typical from them. So schizotypal, usually they have some insight. So if you kind of try to challenge these thoughts, for example, they believe in, say, in certain kind of witchcraft or things like that, they'll be able to say, I know that you will say that I'm a bit odd, but those are my thoughts. So they have a bit of insight towards their thoughts and perceptions. Moving on with the cluster B. So we'll start with antisocial personality disorder, which is seen when one persistently ignores and violates the rights of others. I don't know if you watch The Sopranos, but Tony Soprano is a good example of an antisocial personality disorder. So it's really this tendency of kind of lack also empathy and unfortunately psychopathy can be you can have like on a continuum antisocial and on one part of the spectrum, and then on the other extreme psychopathy, which can explain lots of criminal acts. So you have also the borderline personality disorder, which is a tendency to have unstable relationships, intense mood changes, rapidly shifting self-image, high levels of anxiety, including chronic worrying and intense panic, and noticeably impulsive behaviors. So sometimes these people can also have like micropsychotic features sometimes when they are in crisis. And also I forgot to say that the whole cluster B can be also you can some researchers think that it could be more of an attachment disorder. So it's things that you can kind of that find their roots in the childhood, actually how they've been raised, the amount of kind of the quality of social interaction they had from their parents too. So it's more like of an attachment disorder in that situation. Also, you have histrionic personality disorder, which is a tendency to be highly emotional in social situations, as well as extremely dramatic. Notably, we can say, like, for example, Stella in a Streetcar Named Desire is a good example of histrionic personality disorder. And finally, you have narcissistic personality disorder, which with its pattern of feeling overly important, needing admiration for others, and having lack of empathy too. So there are numerous numbers of people that I can mention. Any people who are overusing social media sometimes can be considered as a narcissistic personality disorder, but more like for example, Paris Hilton, if you want me to give you like an example, which it's really more about feeling overly important over the rest of the people. So now we'll speak about the cluster C. So avoidant personality disorder, which include extreme shyness, feeling inadequate or not good enough, or being very sensitive to criticism. So those are more like the shy people, but in a way that it avoids them from functioning properly. Also, you have the dependent personality disorder, which involves the tendency of needing to be led in making decisions, clinging to others, and having an extreme need to be taken care of. I don't know if you've seen the series Arrested Development, but Buster could be a good example of dependent personality disorder. So it's always needing to kind of be reassured all the time, and the impossibility for them to stay by themselves. Finally, you have the Obsessive Compulsive Personality Disorder, which is a pattern of constantly needing things to be orderly and of wanting to be in control. Of course, you have lots of beautiful examples. If you step in medical students class, I think we all have a bit of that in us. But I think that for example, I think that Batman is a good example of obsessive compulsive personality disorder, but has other personality disorder too. But anyways, it's really this need to be in control all the time and to be in order. So the causes, for sure, so I mentioned, so there are some genes that can really partake in, so the traits can be passed through inherited genes, and these traits are called temperaments, and the environment for sure, so it's really the surroundings the individuals grow up in, and the events that occur in relationship with family members and others, as I mentioned. So it's really, for some, we can really say that it's more like a attachment disorder. So, for example, family history of personality disorder or other mental illnesses, as well as abusive, unstable, chaotic family life during childhood can be risk factors too. And the fact that in the childhood you had a conduct disorder can be a risk factor too. So for the treatment, it's really hard to treat. It's actually, some people, it's well integrated in their personality, so they will really come to seek treatment whenever there's really a disruptive, a difficulty in functioning in their lives. So it's really, so the best way would be to really do intensive individual or group psychotherapy combined with antidepressant if possible. It's really time consuming in terms of treatment, but I feel like for that we should not seek treatment in order to cure the personality disorder, more the areas that are a bit dysfunctional. So more rapidly now, I will just speak about the other disorders in psychiatry. So it's going to be very brief because time is flying right now. So, for example, we'll speak about OCD. So it's the Obsessive Compulsive Disorder, which involves unwanted and disturbing thoughts, images, or urges, which are obsessions, that intrude into somebody's mind and cause a great deal of anxiety or discomfort. And this leads the person to try to decrease the frequency of or presence of the obsession by engaging in repetitive behavior or mental acts, which are the compulsions. So it's something that typically starts in childhood or adolescence. It's really, so the most common psychiatric disorders that are found to co-occur with adults with OCD are another anxiety disorder, for example, or a history of mood disorder, or more commonly major depressive episode. And approximately 1/4 to 1/3 of people have comorbid OCPD, which is the Obsessive Compulsive Personality Disorder. So, for example, I can mention some common obsessions like the fear of contamination, which will be answered by common compulsions of washing and cleaning. For example, also if you have any doubts, like if the door is locked or the stove is off, your compulsion would be to repeat, to kind of overly repeat, to have behaviors of repeated checking. So the course of the disorder, so unfortunately, without treatment, the rates of remission are low. It's about 1/5 of patients. And the OCD is associated also with reduced quality of life, as well as high levels of social and occupational impairment. The treatments are the more common antidepressants, as mentioned previously, which are the serotonin reuptake inhibitors and the serotonin noradrenaline reuptake inhibitors. So now we'll speak about PTSD. So it's a condition that can happen after people see or live through a trauma. And a trauma is an intense event that involves serious injury or death, or the chance of serious injury or death. So the symptoms are quite simple. It's really reliving the trauma through thoughts and feelings, as well as feeling numb and avoiding certain people and places. And finally, having intense feelings such as anger, fear, or worry. So we have a NEMO technique for that, which is trauma, T for traumatic event, R for re-experience, A for avoidance, U for unable to function, M for at least a month, and A for arousal. So how we treat PTSD? It's really simple. We actually recommend as first line a therapy called cognitive behavioral therapy, or the CBT, and there are some medications that can help too. We'll now speak about ADHD, which is the attention deficit and hyperactivity disorder, and it implies that a person will have difficulty concentrating on a given task and paying attention to one's actions. This may lead to careless mistakes, losing objects, and lower performance at work or at school. The hyperactivity means to have a hard time staying in one place and appearing always on the go, to be driven like a motor, etc. Some people, mainly adults, may not exhibit this component of the ADHD. We will now speak about substance use disorder. So a substance use disorder can occur when the recurrent use of alcohol and/or drugs causes clinically and functionally significant impairment, such as health problems, disability, and failure to meet major responsibilities at work, school, or home. So the substance use can have a significant impact on the mood too. In addition, substances can trigger psychosis and alter judgment, as mentioned earlier in the psychotic section.
You mentioned, I think, comorbidity. Could you go over what that is again?
Yes, absolutely. Comorbidity means an illness or a disorder that accompanies another disorder. So it means, for example, the major health problem would be OCD, so Obsessive Compulsive Disorder, which can be comorbid, so which can be accompanied by another disorder, which is OCPD, for example, which is Obsessive Compulsive Personality Disorder.
Oh, so basically you're saying like there's a likelihood that two would go together rather than just having one?
Exactly.
Okay.
I just had a question in terms of like treatments that we use, for example, like exposure therapy, for example. Mm-hmm. A lot of time, like there's an effect, like there's a spontaneous recovery. Like for example, a patient can go through, like for example, let's say phobia. That person recovers, but then the phobia comes back. Mm-hmm. In that case, the person goes back to like let's say CBT, which is an example of exposure therapy. Do you suggest like other kind of therapy where, for example, we take drugs, so what kind of therapy would be good for an individual whose phobia come back?
That is a great question. Thank you for asking it. So for a lot of these disorders too, so what we didn't mention actually is that they can have for many of them, a chronic remitting course as well. So just because, let's say, you have an episode of depression, it gets treated, you actually can have one later in your life. So similar, let's say, to a phobia, even if you go through proper treatment, you may find that later in your life you have some symptoms coming back. So maybe it could just be, let's say, it's a fear of spiders. Maybe you won't feel the full intensity once you've gone through exposure therapy, or maybe you will. So it's not just because you've gotten treatment that we expect that everything is never going to come back. So as to your question specifically, so just to remind everyone actually, so for a phobia, let's say you're afraid of spiders, one of the therapies I mentioned is exposure therapy, where they'll try to get you a little bit more comfortable with a spider, but in a very progressive way. So let's say they'll show you a picture of a spider, then you'll get a little bit closer to one, you'll see a real one, eventually you may even get to touch one if you feel comfortable enough doing it. If later in life, and a treatment success would be that eventually you're at the point where you're no longer distressed by it. So the therapy may work very well, you go on your life. Let's say 10 years later again, you're afraid of spiders for, we're not sure exactly why, but you may re-experience the fear. In cases like that, therapy can sometimes be helpful, even the same type of therapy that you had before. So if you've had a very good response in the past to exposure therapy, Sometimes all it takes is to go back for the similar type of therapy. Instead of having, let's say, 5 sessions, you may only need 1 or 2 to sort of to get back into the swing of things, to remember some of the techniques you worked last time. Keep in mind that the brain actually changes when you're doing therapy as well, and the behaviors actually change too. So it's actually easier the second time around to get back into it. If that isn't the case, you've tried again with exposure therapy and it doesn't work as well, then you have to think of what other options are available. So maybe it could be a different type of therapy, maybe it could be something else that's going on in your life that made it the phobia came back out. In some cases, medications could be useful. So that's really something that just because the condition comes back, it doesn't mean that the therapy was not the right one. Sometimes it could just mean that you need a bit of a refresher.
I want to ask if OCD is curable and which treatment would be the appropriate or the best.
Which treatment? For sure with OCD, it has a good response to some type of medication, but the best way to really work on it would be through therapy. There's like the CBT therapy that we use to work in finding new tools in dealing with this problem. But actually, we usually use more the medication in this situation, which is like the SSRI kind of. The type of medication that we use, which is an antidepressant, but in different doses that we use to treat depression. So that would be it. Okay,
so basically it has to be through a psychiatrist, correct?
A psychiatrist for him or her to prescribe it, yes, but also some family doctors, if they feel comfortable enough, they can prescribe it without problem. As long as there's like a follow-up, there should be no problem normally for a family doctor to prescribe it.
Okay, thank you very much.
Yeah. Or if you're doing CBT, then a psychologist can actually treat, but obviously not for the medication.
Just for the therapy.
Yes, for the therapy, but for the medication it has to be a doctor.
A medical doctor, yeah.
Okay, very good. Thank you very much.
Thank you.
I just had a follow-up question. You've mentioned CBT several times. Could you go over what that is again?
Yes, so CBT is a diminutive for cognitive behavioral therapy. So it's pretty much the most studied therapy that we can provide for many anxiety disorders, actually, as well as depression. So it's more like on ways to kind of work on the behaviors and try to find other ways to deal with them with behaviors, actually. So there are some various studies that have shown that actually it's highly beneficial and that it can change the structure of the brain while having this type of therapy. So thank you so much for being there. It was our pleasure to do this presentation with you guys. And just as a reminder, we'll send you the slides from our PowerPoint for further investigation. Well, if you need it in another time, so it's going to be there. We'll send it to you. Thank you very much.
So I want to thank you again, Melanie and Arwa, for being with us tonight, and from McGill University Psychiatry, and a little bit more on AMI-Quebec. We are here mainly for the caregivers of those with mental illness. We have everything from podcasts to videos to support groups, counseling and workshops. If you're in the Montreal, Canada area, we have in-person workshops. And me actually in April, I'll be on April 4th, featuring a few other members of McGill Psychiatry, in person, in-house, where you can ask questions as well. And I'll give you our phone number on our website as we wrap up. It's 877-303-0264, and you can find all of this information on our website. It's www.amiquebec.org. Thank you again, Melanie and Arwa, and to everyone, have a good night.